And I wanted to review the vascular response to injury. Because we talked about it last week on Thursday. We talked about how endothelial cells can be damaged, and when they're damaged, they're activated, how smooth muscle cells can be damaged, and during any kind of injury, they can be activated, and what those responses are. But the overall response of an artery or a vein, of a blood vessel, is very stereotypical. So what is the first step? What's the first thing that is going to cause some kind of change in the vasculature? Yes?
The endothelial cells go from being antithrombotic to prothrombotic?
Yes. So basically, it's injury to endothelial cells. And part of that is that it goes from anti to a pro-thrombotic state. So normally in a healthy vessel, the endothelial cells are lining the vessel and they are secreting anti-thrombotic agents so that all of your fibrin and platelets that are flowing in your blood all the time stay in an inactivated state. You don't want to clot if there's no reason to clot. So that's a very important feature of healthy, normal endothelial cells. And of course, if there is some kind of damage, you want to clot and start initiating the repair process to that damage. So activation of endothelial cells because of injury is one of the very first steps. So you're not going to get an atherosclerosis unless you have some kind of injury to the endothelium. That's the first thing that's going to happen. And when we talked about etiology of cardiovascular disease, we talked about a lot of the risk factors, a lot of the things that can cause injury to endothelial cells. So we can divide these into biochemical. What are some chemical or biochemical things that can cause endothelial cell damage? Smoking, yes. And there are lots of chemicals in tobacco smoke that get into the blood, either through absorption from the lungs or when you swallow. There's lots of ways that it gets into the blood. And it's circulating. Those toxic chemicals are circulating. And so smokers are at high risk of cardiovascular disease, all different manifestations of cardiovascular disease. Any others you remember? Alcohol does have some properties, although alcohol also is a little bit anti-inflammatory. So, moderate to low alcohol consumption prevents clotting and thins out the blood, but heavy alcohol consumption can contribute to endothelial cell damage. What were you going to say? Alcohol? Okay. So other things, yes, over here. Alcohol is a neurodepressant, so it does, I don't know what its direct effects on the heart are, but it does slow down breathing through its effects on the brain. Yes?
High blood sugar?
Yes, exactly. So people with uncontrolled diabetes or who eat a lot of high sugar, refined sugar in their diet, that sugar circulating in the blood is actually toxic. It can cause damage to the endothelial cells through something called advanced glycation end products. And when we get to diabetes, I will try to talk about that a little bit more. But basically, you're adding sugar residues to the endothelial cells, many of the proteins that are expressed on the endothelial cells, and that actually triggers, it activates them to go into this prothrombotic, highly secretory injury response. And then the other big one are lipids. So doing a little arrow. Lipids. And these are cholesterol and triglycerides. So lipids circulating in the blood are also a risk factor. They can cause damage to endothelial cells. And we'll see more about that when we get into the pathogenesis of it. So we have biochemical. Then we have they're immunologic. So chronic inflammation, systemic inflammation, I'll say, is now considered a risk factor for atherosclerosis and vascular disease. And the other thing we've seen are the type 3 hypersensitivity, those immune complexes that can deposit in the vessel walls and trigger inflammation of the vessel. So they're actually causing endothelial damage by depositing in between those cells or on those cells. And remember, those antibodies that form the immune complex are then recognized by the immune system, activating the immune system and causing inflammation. So immunologic, both systemic inflammation or immune complex mediated inflammation. Or pathogen mediated. So there's new evidence that infection may predispose people to atherosclerosis. And they're still trying to figure out which pathogens, what type of exposure, and all of that. But they have found pathogenic antigens from many, many different types of bacteria and viruses in atherosclerotic plaques. So it seems like pathogens may also play a role in that. And then the third category, and we talked about this last week, was hemodynamic. So this is increased blood pressure. Hypertension, increased blood pressure. What does that do to the vessel? Yes, wall stress. So it increases the stress that is put on the wall, and that is transmitted as a force into those smooth muscle cells and activates those. We also have turbulent blood flow. And so you saw in that plaque, the plaque actually increases turbulence of blood flow, and so that is going to increase injury to the endothelium. So you can see how plaques perpetuate themselves and continue to cause damage. You can also get turbulent blood flow normally at bifurcations. So where arteries split, you'll tend to get more turbulent flow. And that's usually the beginning of atherosclerosis, is where the arteries are branching off because of that increased turbulence. Okay, so that's our first step. So some of these factors have to be present to damage the endothelial cells to start the whole process. And then no matter what the inciting factor is, what's the next response that we talked about? So you have activation of both endothelial and smooth muscle cells. So once these cells are activated, they're starting to secrete growth factors. Smooth muscle cells can secrete extracellular matrix proteins like collagen. And they're secreting other pro-inflammatory factors and pro-thrombotic factors. So you're increasing the inflammatory environment, recruiting leukocytes to the site of damage. And then the third step is intimal thickening. So remember the three layers. You have the intima, the media, and the adventitia of a blood vessel. The intima is the innermost layer, so the endothelial cells, then their basement membrane, and that elastic lamina. That's the intima. And normally, smooth muscle is only in the media. However, when injured, those smooth muscle cells are going to migrate into the intima. So they go into that basement membrane layer right underneath the endothelial cells. And they start to proliferate and they start to secrete extracellular matrix. So you have increased cells and increased extracellular matrix that causes thickening of that intimal layer. And these three steps underlie all vascular injury. So this is just a stereotyped response to any kind of injury. And we're going to look at it more closely in the process of atherosclerosis. So this is an image of atherosclerosis right here. And you can see this is a plaque. You're looking at the inside of the vessel. So the vessel was cut along here and opened up. So this, what you're looking at here is the intima. This is the endothelial lining on the inside of the blood vessel. And you can see at this bifurcation is where the plaque initially developed. So some features you'll notice about this plaque is that it's kind of irregular. Along the edges here, you can see that it's just a raised bump of the endothelium. So the endothelium is still intact here, but it's raised. So that indicates that there's that intimal thickening underneath it, which is smooth muscle cells, inflammatory cells, extracellular matrix, all being built up underneath the endothelium in this area. And then this plaque looks like it has ruptured sometimes. So when a plaque ruptures, it actually releases the inner components of the plaque, and that causes clotting at that area. So this right here is a clot, and here's another clot. The other thing you'll see sometimes with repeated rupture and clotting is you'll get calcification. So if you remember way back to the beginning when we talked about responses to injury in general, dystrophic calcification was one of the responses. And that's where calcium will actually form salts with necrotic tissue, and you get that little calcium deposits in areas where you have exposure, and there's high calcium in the blood, so that calcium is exposed to necrotic tissue when these plaques rupture. So those are the features that you can kind of see here. Now, the epidemiology for atherosclerosis pretty much mirrors what we talked about for all cardiovascular diseases. That people with atherosclerosis, age is a big factor, and genetics seem to play a role. So it does tend to run in families. And these were the non-modifiable risk factors. Atherosclerosis actually doesn't have as much of a predilection for men as heart disease. Women have atherosclerosis just as common as men do. And then we had some of the modifiable risk factors. These are things like smoking, atherosclerosis, and which downstream consequences, heart attacks, are much, much more common in people who smoke. Diabetes. And then we had hypertension, which I'm abbreviating HTN, and hypercholesterolemia, or hyperlipidemia, high blood lipid levels. So these are all modifiable risk factors, and these are the things that we know are going to put a person at risk for developing atherosclerosis. Now, autopsy studies, you may have read about this in your book, they've done autopsy studies because other than that carotid ultrasound, it's really hard to see plaque buildup in a person until they've died. But they've done autopsy studies on just people who have donated, agreed to have their bodies looked at, and characterized the degree of atherosclerosis across ages and across health conditions. And they found that fatty streaks are pretty much universal. Now, these studies are only really done in Western societies, but within Western societies, fatty streaks are almost universally present by the age of 10. Anybody over the age of 10 has some fatty streaks in some areas. But the clinical significance of that is not completely understood. We don't know if fatty streaks always lead to atherosclerosis. It doesn't seem so. But they do seem to track with diet. So people who have higher cholesterol, higher fat diets have more fatty streaks in their arteries. And fatty streaks are caused by foam cells, so they have a similar pathology to more advanced atherosclerosis. So in general, we think of fatty streaks as probably the precursor to atherosclerosis. And they've even found in babies fatty streaks. So it's unclear if that's just a feature of all blood vessels, is that they are at some point going to have these fatty streaks, but then they often regress and grow back over time. What do you think are some clinical features of atherosclerosis? Yes?
I just had a question. Why doesn't the body reverse this?
The body does reverse it. So the question is, why doesn't the body reverse this? And the body can reverse to some degree this process. And so if, let's say that you're 50 years old and you've not eaten very well, and you have a lot of atherosclerosis, and you've had carotid ultrasound that shows maybe 80% stenosis of the carotid arteries. If you put that person on a very low animal protein, animal fat diet, that degree of stenosis can be changed over time. So if it's gotten to the point where there's scarring, sclerosis, that is not always totally reversible. But the atherosclerosis itself, this accumulation of lipids, to some degree can be reversed with removal of the inciting stimulus. So smoking cessation, improved diet, more exercise, actually, which helps to reduce inflammation. Anything that helps to reduce inflammation can help to reverse partially this process. It's a good question. So clinically, what do you think are some important clinical features? Yes?
Would there be pain in the area of where atherosclerosis is?
Why might there be pain?
Does it reduce blood flow?
Right. So there's, in the lower extreme of these, it's called claudication, which is pain. Pain with exercise. So some people, they actually measure the number of steps a person can take before they experience pain. So you just have a person walk across the room. Some people can walk for 100 yards. Some people can only walk for 10 yards before they experience pain in their legs. So that's a measure of claudication. And the claudication from peripheral vascular disease is atherosclerosis narrowing the vessel lumen so that you have reduced blood flow. And when you increase activity, your muscles need more oxygen and more glucose in order to function, and they can't get it because the amount of blood that's able to flow past that atherosclerosis is reduced. So it's not able to meet the demands of the tissue. So claudication in the heart, anybody know what that's called when you experience reduced blood flow to the heart? Clinically? I think I heard it. It's called angina or angina. And it's the same exact thing. This is atherosclerosis in the coronary vessels, limiting blood flow to the heart, so that a person, as soon as they start exercising, if they're not able to meet the oxygen and glucose demands of the heart, they experience that as pain. That pain is the ischemia, the lack of blood flow to an organ. Yes?
So, is angina pectoris specifically like chest pain, and then angina is just like pain anywhere else?
Yeah, I don't know if, I've never heard angina used elsewhere. Angina pectoris is like the technical term for it, but I've never heard them call angina like in other body regions. So usually in the lower extremities, it's called claudication. In the heart, it's called angina. Unfortunately, we don't actually experience pain. Some people say that you could get vascular headaches from carotid atherosclerosis, but quite often the first symptom is either dementia from many little teeny strokes or a massive stroke because it totally blocks off. Yes?
So you have this atherosclerosis in your carotid artery. Could the doctor connect a stethoscope to it and hear the turbulence?
Yes, that's a great question. If you have atherosclerosis, can you hear the turbulence with a stethoscope? Yes, you can, but you have to have a really good ear for it. And the art of the physical exam is slowly being lost in medicine because we have so many other technologies that help do that, that many doctors, it's hard to hear, and you're always a little bit uncertain. And you can compare sides, but it might be bilateral. So it's really hard to see. So many doctors will just go ahead and get an ultrasound anyway to confirm those findings. But if you are, working with Doctors Without Borders or in a third world country where you don't have access to this equipment, being able to detect and hear that turbulent blood flow is really a great skill. So anybody going into nursing or medicine, pay attention to physical exam. I think it's a really valuable and not always highly valued skill to have. Yes?
Would the plaques exacerbate the hypertension?
Right, yes. So it's this feedback system. April asked if the plaques will exacerbate hypertension, right? So if you have hypertension, let's say you have hypertension due to chronic stress or reduced renal blood flow for some reason, now that increased pressure is going to lead to endothelial damage, create this vascular response. You're going to get plaques. What the plaques do is if you get plaques in multiple areas of the body, you get narrowing of the arteries. That's called stenosis. And if you have enough stenosis in enough vessels, that increases your vascular resistance. Any of you who are physicists remember that as you decrease a diameter, you're going to increase the resistance. So the total vascular resistance is what your heart is pumping against. So if that total vascular resistance is high because of lots of atherosclerosis, the heart is doing more work to pump against it. So once one thing happens, it tends to build up upon itself. So that's why we tend to label it cardiovascular disease because very rarely will you have one component of cardiovascular disease in isolation. They tend to cause each other. And so claudication, angina, these are symptoms, pain that you might feel. Most of the time you won't experience any symptoms because your blood vessels are not well innervated, at least by pain nerves. We do have sympathetic and parasympathetic innervation. And so oftentimes you won't have any symptoms until you have a major event like a heart attack or a stroke or gangrene from a blood clot. And we'll look at that again in a little bit. So those are the main clinical features to be thinking about for atherosclerosis. So let's go over the pathogenesis in a little bit more detail, and then we're going to look at some morphology. We'll look at histology and how this plays out. So we start here with a normal vessel. So here's the endothelial lining, and this is the endothelium plus the basement membrane. Again, that's the intima. And then we have a smooth muscle layer, that's the media. And then the outer layer is the adventitia. So that's our normal vessel. The first step is endothelial injury. So something is damaging those endothelial cells and activating them, causes them to round up. As they round up, you're going to get increased permeability. You're going to, as they're activated, you're going to get increased prothrombotic factors. And so you can see some of those are going to cause platelets to stick. Some of those are going to cause leukocytes, white blood cells, to stick. Remember, we saw with leukocyte adhesion that those selectin molecules are upregulated. So leukocytes will start to slow down at that site where the endothelial cells are activated. So that's what's going on here. You have platelet and monocytes. Monocytes are the precursor for macrophages. So they start to stick to this activated endothelium. Yes?
Sorry, what's that top right one saying?
Permeability, sorry. So you have increased permeability, increased prothrombosis. Increased selectins, which help with leukocyte recruitment to the area. So that's going to lead to what you see here. So white blood cells and platelets are starting to stick in sites of endothelial injury. And again, because those endothelial cells round up, you have increased permeability. So macrophages can get into the tissue. The other thing that happens is lipids start to get into the tissue. So that's why if you have high cholesterol or high lipids in the blood, and then you have endothelial damage, those lipids will leak out of the blood into the intima of your blood vessels. So you can see these little yellow dots here are showing that lipids are starting to accumulate underneath the endothelium. And it's this feedback system. So those lipids, once they start to accumulate, will be engulfed by macrophages. That'll help activate the macrophages. Macrophages will start to secrete cytokines that are going to increase endothelial activation, increase vascular permeability. So you can see this feed-forward system here. Once you have a little bit of injury, that injury is promoted further by the lipids and by macrophages coming in. Some of the cytokines that are secreted and some of the growth factors that are secreted by activated macrophages and activated endothelial cells are going to trigger smooth muscle cells to migrate out of the media into the intima. So these smooth muscle cells in the media of the vessel, normal smooth muscle cells are there for contraction. They help control blood flow. But once they become activated because of some kind of vascular injury, they actually change their cell type. So they're still smooth muscle cells. They still look like smooth muscle cells, but they act a lot like fibroblasts. So they migrate to the site of injury, which is right up here. And once they get there, they start to secrete extracellular matrix. They're basically trying to protect and repair the area. So they're secreting cytokines and growth factors and collagen and proteoglycans. So this goes back to what we saw with chronic inflammation and the wound healing response. So they try to initiate a repair process as they migrate up into this area. As that's happening, the macrophages, if there's still endothelial damage present, again, this is a chronic process, they're going to continue to secrete more cytokines. Sometimes they're going to activate T cells and bring T cells into the area. More and more lipids can accumulate in the area. So you can see these macrophages are now starting to engulf all of these lipids that are coming in. The lipids are coming in through the leaky endothelium. Even the smooth muscle cells will start to accumulate lipid, and so it deposits both in the extracellular matrix and in the macrophages and smooth muscle cells of the plaque. Again, here's a T cell, so we've recruited some lymphocytes into the area. And you can see that you have the formation here of that fatty streak. So morphologically, all you see is this little streak, but what's going on underneath the surface is quite a lot. And again, if the inciting factors go away, then at this stage, you can somewhat reverse it, and they think that fatty streaks can be reversed. We all generate fatty streaks, but then we can repair the process. The macrophages will eventually die off, and you can go back to normal. However, most people who have high blood pressure, who have high cholesterol, who have uncontrolled diabetes, that is a chronic process, and it doesn't go away. So the wound healing is taking place with the chronic repair, chronic inflammation, and you've seen what that can do. So we have chronic inflammation going on here. More and more lipids are depositing. These smooth muscle cells that have migrated in here are actually forming a little plaque, what was called the cap, right under the endothelium. And that's, if you think similar to a kind of like a granuloma, which is a chronic inflammation. It's not the same thing, don't get it confused, but it's kind of the same in that the smooth muscles are trying to wall off all of this bad stuff. So we have a lot of necrosis starts to happen, lipids are accumulating, cholesterol will crystallize inside there. And so the smooth muscle builds up on top to try to block it and keep it contained. So that's the cap that forms there. Meanwhile, they're also secreting extracellular matrix to try to protect the area, to try to initiate the healing process. Along the edges, you'll see some granulation type tissue, which remember was the loose wound repair tissue, and that can undergo remodeling over time. Yeah?
Why are the lipids attracted to the basement membrane?
So the question is, why are the lipids attracted to the basement membrane? And I'm not sure that it's necessarily that they're attracted there, but the lipids are sticky and the endothelium is leaky. And so because the lipids are circulating in the blood at areas where it's leaky and the blood has slowed down a little bit, it tends to just deposit in there. Does that make sense? Kind of? The other thing that happens is that macrophages will secrete nitrous oxide and other free radicals, because that's what macrophages, one of their responses to try to kill pathogens. When they're activated, they secrete free radicals. And that can oxidize lipids, which will cause them to stay in the area and actually trigger more damage to the surrounding tissue. Yes?
You said the macrophages start to eat or phagocytose the lipids?
Yes.
So the waste products are just also in that area?
Yes. So macrophages engulf the lipids, and the waste products from that are also in the area. So the macrophages will, some of them will start to die, some of the smooth muscle in the area will start to die, so that all becomes necrotic debris in the area. And I want to bring home the point that inflammation is a really big part of atherosclerosis. So whatever the inciting factor, even if inflammation is not the initial trigger for atherosclerosis, once it starts, once those plaques start to develop, they stimulate macrophages, which stimulate and produce a chronic inflammation. So the atherosclerosis really is chronic inflammation of the blood vessel wall. And you can see here, they're showing all of the different interactions. So the macrophages come in. Here's LDL is coming in. It becomes oxidized, which can activate macrophages. Macrophages can further oxidize LDL as they become activated and secrete cytokines. And they secrete cytokines, which further increase vascular permeability, so more lipids get in, more leukocytes are attracted to the area, and you end up with this inflammation underneath the endothelium of the blood vessel. So let's look at the components of an atherosclerotic plaque. So here's our endothelial cells. So that layer is still there, and the endothelial cells will become damaged, and they secrete growth factors to replace themselves. So they're constantly dividing and trying to reseal over the plaque. So you'll have endothelial cells in various stages of injury over as the outer or the innermost layer of the atherosclerotic plaque. And then underneath there is what's called the cap. And the cap is made up of mostly smooth muscle cells and collagen. So those are the two most important components of the cap. And the more collagen that is there, it's called a fibrous cap. That's actually a protective response. Because the last thing you want to happen is for your plaque to rupture. And that happens a lot. If a plaque ruptures, it's going to trigger immediate thrombosis, because all of these factors are so prothrombotic, and our endothelial cells are secreting prothrombotic factors that they'll immediately activate platelets, they're going to activate the coagulation cascade, and you're going to get a thrombus. So you don't want your cap weak. You want that cap as strong as possible. The more collagen, the more protective it is. Then underneath the cap, we have it doesn't show it too well here. We have what's called a shoulder. Your book describes it. And the shoulder is the area between the core, the necrotic core, and the fibrous cap. And that's where you're going to have a lot of the cells. So the macrophages, foam cells, lymphocytes. And they're kind of acting at the interface. They're the organizers of the plaque. And then in the middle of the plaque is where you have your foam cells. So these are the really lipid-laden macrophages. They've engulfed a lot of lipid. You have extracellular lipid. You have dead cells in various stages of being decomposed. The macrophages are secreting hydrolytic enzymes to decompose the dead cells in the area, which further makes the problem. Some of those oxidize lipids that causes more lipid accumulation in the area. So all of that is inside the center. When you get a lot of cholesterol depositing, it actually crystallizes, and you can see these crystals forming in the center. So that's in much more advanced plaques. You'll see that. And then it's important to notice that that's all taking place above this internal elastic lamina. So here is a normal layer of media. So these are smooth muscle cells that have not gone up, and they've not been activated, they've not migrated into the intima. The atherosclerosis all happens in the intimal layer of the cell. And it's composed of these cells, smooth muscle cells, macrophages, and lymphocytes, extracellular matrix, mostly collagen protein, which is deposited, and then accumulation of lipids. So those are the three main components that make up a plaque. Yes? Yes. It's above so the smooth muscle layer is called the media, and this blue layer right here is the elastic lamina. Remember that we had an internal and external elastic lamina around either side of the media? So that elastic lamina is made up of the extracellular matrix protein elastin, and it gives the cells their ability, or not the cells, the wall of the artery, the ability to expand and contract, that elasticity. So a good corollary of that is now that we've put all this plaque on top of the elastic lamina, it actually kind of stretches it out. You lose elasticity of the arteries. The arteries become hard with atherosclerosis. All right, let's take a 2-minute break before we get into the histology. Yeah, I didn't even know what surgery. It's probably like a renal artery or carotid artery, something like that. Yes. Sorry, I left the recording going, so if you go back and listen to this, you'll hear a lot of chatter. All right, so I had a couple questions about removing the plaque. And that's something they do that's called angioplasty. So you saw the Doppler of the carotid artery with that big plaque in there. As long as it's a stable plaque, they'll actually do surgery. They can cut into the artery and just use forceps, and they can basically peel that plaque layer off, and they pull it out. Yeah, well, you can search YouTube, and you'll find a video on it and see that process, because it's really quite amazing. And then what you have now, you've removed, they only do that if it's a really big plaque. So you're assuming that the majority of the plaque is lipids and foam cells, and you're removing all that. Of course, you're causing injury at the same time. So it's all going to come back if the person continues to smoke and continues to have high blood pressure and other factors, because none of that is going away. But if you can get that plaque gone and then the person can change their lifestyle, you have a really good chance of fully recovering. And it'll probably, there may be some scarring in the area, but the degree of stenosis will go from, they do surgery if it's above, I believe it's above 90%, but you can get that degree of stenosis back below 30%. So look it up because it's a pretty cool process. All right, so let's take a look at the histology of atherosclerosis now. And I just wanted to start with a normal muscular artery. Now, I didn't really mention it, but atherosclerosis mostly happens in the larger arteries. That's because that's where you have a big media layer. You have a lot of those smooth muscle cells. The smaller arterioles tend to respond more with just sclerosis. So remember that picture that I showed you last week and was on your quiz, the arteriosclerosis? That happens in the smaller arteries, especially in response to a lot of turbulent or high pressure. Atherosclerosis happens more in the larger muscular arteries and the medium-sized arteries like the coronary vessels. So let's just look at a normal muscular artery, and you'll see here is the lumen. This white part's the lumen. Here's that elastic lamina layer right here. So that ruffled appearance is because we have that elastin. You can't see the very thin endothelial layer on top of that, but that right along here is the intima. So there's endothelium, a layer of basement membrane, and that elastin. Then you have a very large layer. All of this is smooth muscle. You can see it has a pretty uniform appearance. There's striations circumferentially. You can see these little faint purple nuclei of the smooth muscle cells. So this is the media composed of smooth muscle. And then out here, this loose tissue is the adventitia. So that's extracellular matrix, and then you have a lot of small blood vessels in there to supply the outer layer of the artery. It also provides the outer wall of your blood vessel to hold everything together. And here's the drawing, the cartoon drawing that we reviewed of that last week. So fatty streaks tend to be the first change that you see in the blood vessels. And it's really hard to see on here. If you look at the slides on the PDF, you can kind of play with the contrast a little bit. But here is a fatty streak. Now, this is probably the aorta cut open, and so you're looking at the inside of the aorta, and these little holes are the dorsal vessels going to supply the muscles of the back, and they go and supply the spinal cord. So that's what makes me think this is the aorta, probably the thoracic aorta. And you just see a little fatty streak right here. You can see a little bit right here. If you cut into the artery and look at it in cross-section, here are the smooth muscle layer, the smooth muscle cells of the media. Here is your, right down here, you can see this is the elastic lamina. And then underneath the endothelial cells, but above the elastic lamina, you start to get foam cells. So you can even see right here, this is a nucleus of one of these long, flat endothelial cells. And then underneath it, this is a macrophage, a foam cell. So that's the first change. That's what's causing these fatty streaks. You have a little bit of lipid that has come underneath the endothelium, and some macrophages have migrated in and engulfed that lipid right under that layer. It's kind of pulled a little bit away from the elastic lamina. That indicates that vascular permeability. There's some leakage of fluid into this area. Any questions? Here's a gross image of a plaque. So before you saw it adhered to the wall, this has been removed from the wall of the vessel. So this is the plaque itself. So you can see that there's a lot of kind of gooey necrotic stuff here. This is a little bit bloody. It's hemorrhagic. Probably there's been some thrombosis going on. You can actually get bleeding into a plaque sometimes. And you can see this, like right here, this is probably calcification. Yes?
When they remove the plaque, are they removing it from the wall or are they removing it with?
They're removing it from the media. So remember, the plaque is forming on top of the elastic lamina, but so when they remove it, the endothelium is going to come off with it because it's a very thin layer, and they're basically peeling it off from that elastic lamina. So the media is left intact and the adventitia is left intact. And then the hope is the endothelium around that area will grow back over it. Now, if you look at the plaque, let's look at this side. So right here, this area right here is the cap. The area right underneath it, here you're starting to see a lot of necrotic debris. And in this case, you see that pink stuff is probably fibrin, so you get fibrinoid necrosis. And again, this fibrinoid necrosis happens in blood vessels because fibrin from the blood leaks into the wall of the blood vessel when you have a lot of necrosis activating inflammation of the area. And then all of this down here is cholesterol crystal and lipid. So this cap is where you would see smooth muscle cells, inflammatory cells up close, and that's what you're seeing over here. So you see here's a cholesterol crystal, but here are a lot of foam cells in the area. So these purple nuclei, those are lymphocytes and monocytes, macrophages. Maybe you'd even see a few neutrophils, but more likely to be lymphocytes. This wavy pink stuff here is extracellular matrix being deposited, so collagen mostly. And then right here, this darker pink stuff, and you can see it over here too, that's fibrin. Does it look like fibrinoid necrosis? It looks like what you've seen before with vasculitis. So this is fibrin leaking. It's a plasma protein that's leaked into the wall of the vessel and coagulated.
What part was the leukocytes?
So these purple nuclei here are leukocytes. And some areas you'll see a lot, and some you won't see as many. So there's quite a few inflammatory cells down here. So the extracellular matrix is kind of this smooth, wavy, pinkish stuff right here. So there's no cells in it. It's largely collagen fibers that have been secreted. And then the dark pink is the fibrin that's leaked out from the blood. Okay. I encourage you to go back and look at the histology. It's really interesting, and it helps you get a feel for putting it all together, for understanding what's going on with atherosclerosis. So I just briefly wanted to mention the clinical progression. We talked about the start with a fatty streak, and how if you have chronic stimulation, chronic activation of endothelium, that fatty streak can progress to, here they call it a fibrofatty plaque. That's because the lipids are accumulating, so it's fatty. The fibrin, the fibro is referring to the fibrous cap that forms over the top of it. So that's smooth muscle plus collagen, the extracellular matrix, forming a cap over the top of it. But with repeated ongoing injury, you get more and more lipid accumulation, more and more inflammation, and you get this advanced plaque. Oftentimes, as the plaque gets bigger and bigger, that cap over the top starts to get weak. So you're not producing enough collagen to contain everything that's going on in there. And that's when you start to get symptoms. So this advanced plaque might rupture. It might rupture out of the outside of the wall. It might rupture into the lumen. So if it ruptures out, that's you're going to get bleeding. You can get a hemorrhagic stroke from that. If it ruptures into the lumen, which is the more common, you're going to get thrombosis. You're going to get a blood clot over that plaque and completely block blood flow past that area. Or it might just grow to the point of what's called critical stenosis, which is 90% blockage. So if that lumen is decreased by 90%, only 10% of normal blood flow goes past it. That's called critical stenosis. That's when you start to get symptoms. Usually you can even get symptoms at rest from that. So somebody might just have a lot of pain, heartburn, or not heartburn, angina, if they have 90% stenosis of a major coronary vessel. Yes? Why do you not get symptoms? So you do get that claudication. So you get symptoms with increased demand. Roughly around 70% is where you start to get some symptoms. But oftentimes people will just say, oh, I have sore muscles because I don't work out very much. They often don't make the connection that it's because of vascular disease and not enough blood flow. So that 70% is symptom with exertion. 90% is critical symptoms at rest. And it's because your blood vessels actually carry more oxygen than you typically need all the time. So, you have your blood is, as it's circulating around, it's delivering oxygen and glucose, but there's still oxygen and glucose in the blood to spare. So the tissues are getting access to all that they need unless blood flow is reduced by about 90%. At that point, even at rest, you're not able to get enough oxygen to the tissue to supply its basic basal metabolic needs. Okay. So I encourage you in your study groups to look at this. I'm going to move on and just go over the blood vessels really quick to try to tie it together. But definitely, these are the most common vessels that are atherosclerosis tends to build up in. Infrarenal abdominal aorta. The renal arteries branch off around mid-back. And below that, before it bifurcates into the iliacs, that's where you tend to get a lot of atherosclerosis. The popliteal arteries, those are running behind your knee. Internal carotids, we've already talked about. And the circle of Willis. Who knows what circle of Willis is? Yes?
The arteries in your brain?
Yeah, it's the arteries. They come up from the vertebrals and the internal carotids. And it forms an anastomosis, which is a connection of blood vessels, all the way around the base of the brain. And so it's this dual supply to the brain, so that if there's occlusion in one, it goes around. But the circle of Willis tends to build up with atherosclerosis quite frequently. So why do you think that happens? And what do you think would be a clinical manifestation of atherosclerosis in those vessels? I'm not going to go over it right now, but think about that. We're just going to spend the last 5 minutes looking at atherosclerosis at various stages, because I think it helps to see it in the whole vessel. So I think most of these are coronary vessels because that's where you see a lot of atherosclerosis and a lot of research has been done. Here is the adventitia all the way around. This is a normal part of the blood vessel, so there hasn't been atherosclerosis developing in this area. And you can see this media, this middle layer, is quite normal. Now, these little flaps right here, that's just a histology error. So they're taking very thin slices. Sometimes the tissue folds on itself. So that's what this is. This is just folding of the tissue on itself. It's not actually any real pathologic finding. So this is normal media right here. This, in the same vessel, here's the media going around, and all of this inside of it is plaque. So I'll try to trace it for you. So there's the plaque. So there's a lot of plaque in this area. And you can even see from this high or this low-powered view that there's probably crystals developing in here. So this area and here, there's a lot of crystals developing. Over here, this is probably on the edge, you tend to see granulation tissue. So this is where you're developing growth factors, extracellular matrix, smooth muscles, trying to start the repair process. And the lipids have accumulated in here. So we have, this is the necrotic core. And then this area right here, between here and here, this is your cap, the fibrous cap. So for most of this vessel, the fibrous cap is actually relatively thick. Over here it gets a little bit thin, but then over here it's okay again. So this would be called a stable plaque. And the main feature is that you have a pretty thick cap over it, so you know that that's stable. And then comparing it to the one next to it, where you see that there's probably been some hemorrhage into this because of the fibrin that's deposited in here. This doesn't have that. So it hasn't ruptured, most likely, yet at this point. So that's another indication that it's a stable plaque. On this side, this one is also has a pretty good cap over it. This one actually seems to go across the whole vessel. So that's the cap. And then underneath it, in the necrotic core, you see a lot more of that fibrin and fibrinoid necrosis going on. Probably there has been leakage of blood or fluid into the plaque at some point, and then it's reformed over it. So this one demonstrates remodeling, which is a feature of chronic inflammation. Remember that as you generate that extracellular matrix and granulation tissue, it goes through a process of remodeling over time. So this cap has been remodeled, or this plaque has been remodeled. And again, over on the edges, there's probably some granulation tissue going on over here. You can see on this side of the vessel, there's still some plaque, but it doesn't have the same necrotic core. So it's at a different stage in the development. So one thing we know about atherosclerosis is that it can cause, atherosclerosis in one place can cause more atherosclerotic plaque to start to develop in a neighboring area. And you can see that's probably what's going on here. This is a more immature plaque, and this is a more mature plaque. And then this one has just ruptured. So here's your vessel, here's the media. The plaque is in the intima all the way around. Here is outlining the lumen of the vessel. And all of this pink inside here is thrombosis. So you can even see over here, this is where the cap has ruptured, exposing the necrotic material underneath to the blood. That activates the coagulation cascade. It activates platelets, and they form a clot immediately over that area. This vessel has been totally occluded. So that's the worst case scenario for atherosclerosis. All right. Richard. Oh yeah, some of these slides I didn't include in the original lecture, so yes, I will post the PDF.